Welcome to the Digital Healthcare Experience, brought to you by Taylor Healthcare. Subscribe now and stay on the forefront of the digital healthcare revolution.
Hello and welcome to the Digital Healthcare Experience podcast presented by Taylor Healthcare. I'm your host, Chris Civitaris, and today I'm joined by Dr. Doug Slakey, internationally recognized transplant surgeon, healthcare professional, and administrator with 30 years in clinical and business leadership. He's the best-selling author of the Process Manifesto, Improving Healthcare in a Complex World. As the president of Process Health Consulting, Dr. Slakey is highly committed to a philosophy of patient-centric medical care. He recently started a new role as professor and chair of health system sciences at Belmont University, where he's pioneering a platform dedicated to the comprehensive study of healthcare delivery. And we're definitely going to talk about that more today. And his previous experience includes 5 years at Advocate Aurora Health, where he served as chief of surgical services. And prior to that, he spent 21 years at Tulane University as professor and chief of surgery. Doug, thank you so much for joining us. Welcome, and it's a pleasure to have you on the show.
Oh, well, thank you so much. It's great to be here.
And I'm really excited to talk about the work that you're doing at Belmont University. And I'm also excited to get into some of the topics that you covered in your book, the Process Manifesto. So I'm hoping that to start, we can just jump into a little bit about your background and a little bit about your role at Belmont University. So if you'd like to start there, that would be great.
Yeah, sure. So as you mentioned, transplant surgeon by training, liver, kidney, pancreas. Like many of us, I took sort of a circuitous route, Wisconsin, Oxford, England, Johns Hopkins, and then, as you mentioned, down to Tulane for 21 years. And, you know, a really pivotal point in my career was actually Hurricane Katrina. So after Katrina, I decided we as a family decided to stay in New Orleans and contribute to helping rebuild, in my case, healthcare in the Gulf South. And I really started to think about access to healthcare and the distribution of services, and also topics like reliability, complex system management, and team empowerment. You know, how can we put all that together to really try to make a difference? So that pivot in my career, although I kept clinically active, very clinically busy, I really devoted myself to thinking about those topics and trying to contribute. So that led to being recruited to Chicago, to Advocate Aurora, where I really focused on high reliability and process improvement, and particularly process improvement from the perspective of the patient. You know, so often we think in terms of our work environment, especially in healthcare, right? We think about the hospital, we think about the walls of our clinic space, or in the case of a surgeon, the four walls of the operating room. But we really don't consistently think about what I like to call the patient journey. How does the patient interact over time? And so after the contract expired in Chicago, I took a short sabbatical and wrote this book, The Process Manifesto, started doing a little consulting. And then, as so often happens, you wind up meeting someone by happenstance. And I met the dean of the new Frist College of Medicine here at Belmont University in Nashville. And we were talking, and he said, well, you know, I've got this health system science department, and we don't really have anyone to lead it. Not sure you'd be interested. And so anyway, I wound up here, and I'm super excited about this stage in sort of my career, because it's kind of the culmination of thinking through how do we actually bring stakeholders and thought leaders together and really sort of have a design thinking process or an open source innovation platform where we can actually consider how do we improve the delivery of healthcare and some of the models around that, the processes and other aspects of our complex healthcare systems to really focus on patients. And that, I think, is what really is going to differentiate us, and what really makes us excited is when we look at everything from technology to process improvement to leadership training, we're doing it through the lens of what does the patient think. And I really think that's a little unique in this world, in this environment. And so I think we're going to really offer something to people that will really help open their eyes and get them thinking in a broader context.
Yeah, it's fantastic. And you mentioned a few things that were themes in your book as well, in terms of a process-oriented approach, the notion of everything being patient-centered, the importance of leadership, I think you touched on. So let's talk really fast about the book and sort of how it informs what you're doing with Belmont and some of the themes that you're trying to address there.
Yeah, well, the book was like many sort of these books, it's kind of a labor of love and accumulation of things. And at fundamentally, my hypothesis in writing the book and what I try to describe is that healthcare truly mimics a complex system. And all too often, I argue this in the book, we've tried to reduce complexity to a highly predictable linear structure, sort of like an assembly line, right? And some things in healthcare, like patient registration, it might lend itself to a linear process, but most of it does not. And when you think about the consequences of reducing complexity to a linear structure, a couple of things happen. One is from a business perspective, key performance indicators often don't align with what the ultimate outcome goals truly are, especially from the patient perspective. So even simple things like reducing length of stay, you say, okay, well, that's a great idea. We want to reduce length of stay. So that's a key performance indicator. But, somebody who's healthy can have a surgery and be discharged at 7 or 8 at night the same day of surgery. But what about the person who lives 3 hours from the hospital, maybe lives alone, doesn't have family support? Is it really in their best interest to just discharge them at 8 at night after a major surgery? And I think, from a human perspective, we say, well, no. And do we always align the resources? So sort of a simple example, but I think it's fairly telling as some of the limitations. And the other thing that I think is a tremendously important consequence is the relationship of this reductionist theory to disenfranchising professionals and patients to a certain extent. But think about what we're seeing with nurses and physicians with burnout, with lack of retention, with disillusionment with their job. Even suicide rates are unfortunately going up significantly for both nurses and physicians across the country. And when you think about it, you think, well, if we're trying to make them work in a very highly structured assembly line type of process, what are we saying about their professional skill, their training, their education, their judgment? Are they really able to react and deliver the care, which ultimately is what led them into the profession, right? This idea that you're treating fellow human beings and you're trying to get the best result for each individual. And so that's really at its core what I try to talk about in the book and get people thinking maybe in a slightly different way than they have been for the last decade or so.
Yeah, it's really interesting, and obviously, it seems foundational to all the work that you're doing in the field. And obviously, that work has led you now to Belmont, where, as you mentioned, the institution is creating the Center for Health System Science, and that seems really unique. So I'm curious, can you elaborate a little bit on what motivated the initiative and the significance, and sort of why this is so unique in the industry?
Yeah. Well, I really thought to myself, when I reflected on what could I contribute, how could I contribute to this, and I looked around, and health system science is fundamentally this idea that we should be educating members of the healthcare community, starting with medical students and nursing students, about the systems in which they're ultimately going to work. And of course, for people in many areas of business, that sounds like common sense, but we've never done that in healthcare. So that's at its foundational core. But then as you expand beyond that, you realize that this idea of health system science as a construct can really incorporate so many aspects of improvement, of really trying to study what's going on with our healthcare system currently. And so I look at it as the ability to understand how the healthcare systems are truly interacting from a purely academic research perspective. And then layered on that, the ability to incorporate different stakeholder perspectives, which is so important, right? Sometimes we have a very myopic focus, whether it's, a surgeon like me or an individual hospital or an individual clinic. We tend to focus on what we know, not the greater perspective of what the patient actually sees as they seek care. And then my hope in creating this center, I thought this would be a perfect opportunity for sort of an open source innovation, a very neutral platform. There are certainly wonderful opportunities for people to come together and share ideas in healthcare. But often there's a bit of a transactional element involved. There's some aspect of sales or self-promotion or that sort of thing. And what we're hoping to do here is really create this kind of neutral platform without that. And then my goal is, as we put the team together and solidify what we're doing, is to be able to study, to test, in other words, implement innovative solutions, and then to scale them. And those three elements are really at the core of what we're looking at for deliverables. And so we've picked 4 focus areas. Health system science, as you could imagine, when you start to think about it, can be, I use the buzz. Yeah, well, I jokingly say it's like Buzz Lightyear. It's to infinity and beyond. And obviously you can't do that. So we've picked 4 focus areas that align with the mission of Belmont University and the Frist College of Medicine, and also with sort of our core faculty interests that we're starting with. So one area of focus is global and environmental health. A second area of focus is the business of medicine, with a particular emphasis on what are those aspects that drive value in the healthcare system. The third is what I like to call the context of health. So I think most of us are familiar with the term social determinants, and in that we often think about things like economics, but the context of health is even a little bit broader umbrella that includes things like, well, do you live in an urban or a rural setting? Do you, for example, live in a very remote setting, whether it's in the desert Southwest, perhaps a Native American reservation would be an idea, or something like in a rural Alaska, where in the wintertime you might not have the ability to travel easily to a facility. So the context of health is this broader and much more, I think, nuanced area, which I'm particularly excited about technology being able to help us grapple with those complexities. And then the fourth area is actually the intersection of technology and healthcare, again, with a specific emphasis. And in this case, the emphasis is on how does the technology empower the patient to make their journey more reliable and consistent over time.
Yeah, it's really interesting. And I want to touch on that sort of intersection between technology and care delivery. Obviously, I mean, the pace of technology throughout our lifetimes has changed at a fairly breakneck pace, and especially now just in the last couple of years. And it's wonderful to see all of the new opportunities that are arising from a technology perspective to address some of those really big sort of ideas and issues and problems in healthcare. And in your book, you also talk about data driven approaches to making decisions and things like that. So I'm curious, can you elaborate a little bit on the intersection of that technology and care delivery and how you evaluate, whether new technologies are truly going to sort of deliver on the promises and make those impacts that you alluded to?
Yeah, well, I think in my mind right now, there are two sort of key principles that we need to focus on. The first is that from the healthcare delivery side, we have a lot of data, a tremendous amount of data. Now, unfortunately, much of that data is acquired as it relates to the revenue cycle. So, so much data is from billing and claims. And you can argue whether that really reflects the patient's interest or the healthcare system's interest, the way that data. But anyway, we have a lot of data, but we don't always have, from the care delivery perspective, actionable information. We tend to look at data very retrospectively. And I can tell you from personal experience, you get a group of physicians or nurses together, and somebody comes up with some Excel pivot tables that have data that's 6 to 12 months old and is massive amounts of data. And everyone shrugs their shoulders and says, well, what am I going to do with that? Where what we really need to do is translate that data. And this is so exciting with the new technologies that are evolving, including AI and machine learning. But we need to evolve that data into helping people make informed decisions that meet the needs of the individual patient so that we can align resources, protocols that make sense for the patient. And that's where the human interaction, everything from situational awareness to communication to experience, becomes so important, right? So actionable information. The second thing that I love to really think about and focus and hope people focus on is how can we use modern technology to actually empower the patient to have more engagement and more reinforcement in their own healthcare journey. That's it. You think about some other, common technologic advancements that really empowered the consumer, like rideshare is a good example, right? It wasn't that long ago that you had to find a taxi queue and you had to line up. And, now it's this fluid on-demand system where, albeit there are sometimes challenges, but in general, the consumer has much more control over the experience. And one of my hopes, and one of the things that I really look forward to studying, is how can modern technology in the healthcare environment have the same sort of positive effect for the patient? How can we really empower them to do better? If I could, I'll give you one, example
Please.
that I've used recently. I said, so, there's several AI companies out there that are optimizing, for example, clinic scheduling, right? And they say, okay, well, we can optimize your clinic scheduling, and instead of seeing 23 patients a day, we'll get you 26 patients a day. And to the billing side of the house, the chief financial officer, the clinic manager, that sounds awesome, right? We're going to get 10% more patients, we're going to get more revenue. But to both the patient and the physician or the healthcare provider, is that really an advantage? They're already overwhelmed. They already feel like they're not spending enough time being engaged. So think about if we changed the construct and we said, wow, we're going to use technology to monitor this population of patients, and we're going to help patients make their healthcare more consistent. We're going to monitor, how their exercise activity is, their diet, their compliance with medications, all those things together. And then you know what? We're going to identify the patients that most need the personal visit with the physician. They're most at risk. They're having an acute or potentially an acute problem that we can intervene and prevent from getting worse. Actually, when you think about it that way, it's an amazing opportunity. And as a physician, what do you really want to do? Mostly, you want to see the patients in your office who you can benefit the most. You don't really need to see somebody who's perfectly stable and you're interacting with, perhaps through technology and AI, and you're reassured that they're doing well. You want to be able to devote more time and more thought and more of your skill to those patients who really need you the most at any particular time.
It's really interesting. You touched on something too. There was just an article in the Wall Street Journal fairly recently that talked about sort of the shift to hospital at home and
Yeah.
all the benefits, but also some of the challenges in terms of standardization of care and delivery and some elements that you're, obviously, really passionate about. So I'm curious, as we think about sort of the future of that delivery model, if you will, maybe extending beyond, as you mentioned earlier, the four walls of the clinic or the health system or the operating room. Do you see challenges in terms of that standardization of process and so on and so forth?
Yeah, well, I see a couple of big challenges. One is, fundamentally, we have to address the sometimes perverse incentives of our payment model.
Hmm.
So the hospital at home is a great example. If you, it's very ironic. We talk about reducing length of stay, but then if you're running a hospital, you want 100% capacity. You want somebody filling every bed every day. And so, there's this disincentive for some of these new approaches. We know some of them are better, like a well-managed hospital at home, shorter length of stay. We know that the in many aspects of clinical outcomes are improved, but the payment models are not always in alignment. And so, that's one of the challenges really to grapple with. The other element that I think is really important, and this is where technology can really be leveraged, is that we have to understand what are the implications of the context of health as we look at people. I'll give you another example that I use sometimes. I say, well, so I could see two patients, same age, that need a hernia repaired, right? Same exact hernia. I do my little checklist, and they both have diabetes. They both take the same amount of insulin. They both have the same hemoglobin A1C. So we check those boxes in the electronic health record. We pat ourselves on the back and say, oh, we're doing our job. Well, we don't change the consent form at all or look at anything else. And you say, well, those patients probably have the same risk factor. They should have the same care. But what if I told you that one of those patients lived in a college educated household, plenty of resources in the suburbs? The other was a single person in public housing who lives alone with no car. And unfortunately, in the current setting where we've reduced everything to these standards, we tend to treat those two people identically. And common sense would tell us that their needs are much different. So when we look at technology, given a point like that, what we want to do is we want to be able to pull in all this information, this context of health, information and be able to individualize the treatment plan so that we can align resources with need. The person in the suburban, household with a lot of resources, they probably don't need anything, right?
Right.
They can probably honestly get up and do most of the physical therapy themselves. The person who's in public housing with no transportation and lives alone, they probably need food resources. Maybe they live in a food desert. They clearly need transportation to get to and from the hospital, or else they may wind up in the emergency room, not unexpectedly. And so a lot of different resources. And if we could imagine, if we had the ability to individualize the treatment plan and align resources where they were most needed, that's where we really create value. So instead of taking this just massive shotgun approach that really aims towards the average, right? That's what we try to make everybody the same and make them all average. And human beings aren't that way. So this is where some people have thrown up their hands and say, well, nothing I can do about it. But, I'm really committed to trying to use this health system science center as a platform, as a construct where we can start to bring experts together and really try to address some of these problems and see what are solutions that might work.
It's really interesting, and I want to go back also to the notion of testing and the ability to use a process and a philosophy to really measure effectiveness, reliability. And to your point, are we actually getting to the results that we would expect based on the objectives of a particular technology or strategy or what have you? So if you can, talk to us a little bit about the processes that you do advocate for in terms of testing and how it relates to measuring that effectiveness and reliability of particular projects.
Yeah, so I think there's a couple of really interesting approaches. So one is, and fortunately, like many medical schools now, we have this amazing simulation space. In the new building here, we have 2 entire floors that are completely devoted to simulation. So you can actually bring teams together and explore over time how different technologies and different processes and approaches actually work in a simulated environment. And what we want to do in those cases, in my opinion at least, is we really want to focus on the unexpected. If you ever go to say a commercial airline pilot training center, they don't focus on the routine flight per se. They really focus on what's going to happen when you have a bird strike or that, engines go out. So you can, land your plane in the Hudson and save all those lives, right? That's what they focus on. And they don't just focus on the technology itself. This is so important. They focus on the interaction between sort of the human factors. How do human beings interface with the technology? How do they communicate? And one of the things that I think we can really do better is to not only test these in a simulated environment and maybe also out obviously in the real world, but we can use that information to then create meaningful education to help people really use the technology better. I think that's one place where we have a tremendous amount of work to do in healthcare. So often, the technologies and devices we use, many of them are obviously remarkable, but they're extremely complicated. You think about the iPhone, right? The beauty of the modern, whether it's an iPhone or an Android or whatever, you get them a brand new one and there's no instructions. And I think any of us who've been around young children know that by, whether it's good or bad, that by 18 months, they're able to flip through and take pictures and do things, right? try to understand the install of an electronic health record in a clinic or a hospital. It's almost it's very challenging, and it's rarely intuitive. You have to have a lot of repetitive use and counseling. The downside of that is often people just get their routines and they cut and paste, and you don't know the veracity of the data that's being entered is often questionable. So with technology, one of the things that I really want to do when we're studying it is figure out, how can we make it accessible? How can we make it reliable? How can we have something that right out of the box, as it were, works for people? And then, the next step with that is, how do we educate the leaders of healthcare systems? How do we educate patients? How do we educate the frontline healthcare workers to use and integrate technology most effectively? So I know that was a few different things, but I think they're all elements of a thread that are incredibly important.
Yeah, absolutely. Especially that notion of, to your point, not only does the technology work, but that human element of how that technology and the human sort of interact with each other. And, not just from a physician or a nurse perspective, but how it affects the patient, and sort of bringing it all
Right.
together. Whenever we talk about sort of that stakeholder view of the world, the question that always comes to mind for me is, sometimes you have sort of like competing, goals, objectives in that stakeholder view. How do you balance all of that?
Yeah, well, that's really that brings me back to the book, The Process Manifesto, because you have to, and this is so important, you have to begin with what the end result is going to be. You have to start there, and then you have to engineer backwards, as it were, to figure out, how do you make those processes actually work to create that end result. And the end result should be, in my opinion, improvements in patient outcomes. And patient outcomes that are meaningful to the patient. That's another, we could spend a whole hour on that. But, sometimes the outcomes we choose are important to me as a surgeon, but, or, any physician, but are they really truly important to the patient? So we have to put that in context. And then the second thing, and this is where technology, I think, if we consider complexity, can be so valuable, because what we want to do is we want to empower people at the intersection of patient care, from provider, whoever the provider is, whatever their degree or designation is, and the patient, whether that's at home, whether that's in the clinic, or whether that's in the hospital. And I will tell you, for many people in leadership roles, that concept of decentralizing and pushing responsibility out to the front lines is, frankly, scary or a bit intimidating. That this idea of a centralized control model seems reassuring to many people in leadership. But at the end of the day, if we over centralize and over reduce our processes to linear standards, we're not actually taking advantage of our investments. And so I want to finish this with one thought. So if you start to think of high performing professionals as capital as opposed to cost, then it starts to change your thinking. You say, okay, I've invested all this money in these high performing professionals. And we invest a lot, right? Like, my first real job wasn't until I was 37 years of age with all the training. I mean, it's
Right.
amazing, right?
That's right.
And you think, okay, well, that's a huge investment, personal, professional. and societal, because we're all helping to support this. So isn't it incumbent upon leadership to make sure that those highly trained professionals are in the best position to do their jobs efficiently and effectively? And I argue in the book, and I really think this is true, that while we need normative standards, that's obvious. We need, normative safety standards. We need to come up with ways that really engage people and allow them to work at top of license at the point of care delivery.
That's it makes so much sense when you sort of say it out loud. And there's still so many sort of barriers, right, across the board to sort of get there. I think that's why the work that you're doing is obviously so important, because, that hopefully is the future of medicine, both from sort of that provider side and certainly from the patient side. I'm curious. I know we're just about at our time here. Looking ahead, talk to me a little bit about, the goals for the Institute, the goals for the center, and how you are, envisioning it impacting healthcare as you grow and as you mature with the center.
Yeah. So that's that.
I know, a loaded
It's
question that we
actually,
saved for the very end.
yeah, it's a loaded question, but I think at its core, I have in my mind conceptualized three elements of delivery. So one is this idea that we should really be a resource for bringing opportunity together for people who want to study novel approaches to improving healthcare, whether that's in a simulated environment or whether that's relational with healthcare systems, community organizations, whatever the case might be. So study and research. And then I also, as I mentioned, like to consider implementation and scaling, because if we can't scale things, it's not at the end worthwhile. We have to be able to scale. So that's one bucket of deliverables. The second bucket is education. And we touched on this, but I think it's often been ignored to date. We have to educate people broadly. So medical students, nursing students, yes, but then we really need to be able to educate leaders, people on the front lines, patients. How do we get this information and disseminate it and create education that makes sense to people, right? That actually is meaningful and allows them to consider alternatives to the status quo. And then the third deliverable is what I call communication. So that could be everything from scholarly publications based on research to white papers or policy papers, seminars, maybe even a podcast like that, like your excellent podcast. But communicating, this information, and again, from the perspective of how is this work actually translating to meaningful improvements for patients, for people. And I will tell you one of the things in my book. So I was very fortunate and blessed to have some amazing people read my book and give me ideas. And when you write these sort of books, you have to come up with your core principles, right? So one of the core principles, and it's number 10, some argue it should be number 1, but is compassion. And I really want to, sort of conclude with this, that at the foundation of the center that we're developing is this idea that we should all take a step back and consistently focus on the need for compassion, the need for really considering what are our contributions and our ideas doing for human beings. And I came up with this concept that I'll sort of finish with this, that as I thought about the book and I thought about what we're, really trying to achieve, we often create these in my mind, false dichotomies, us versus them, patient versus physician, physician versus health system, everyone versus the insurance company, these sort of false dichotomies. But again, if you think about it through the lens of compassion, at some point in our lives, each one of us is a patient and each one of us is a caregiver. It's an inevitable reality of human existence. And so within this center, I'm really making sure that concept stays at not only the foundation, but right at the fore, at the front of what we're doing when we consider new things. And I think that helps us keep perspective that's healthy.
Yeah, I think that that's a perfect place to leave it. Certainly here's hoping that compassion continues to, drive the healthcare industry. And frankly, maybe the world could use just a little bit more of a reminder of that as well these days too. So I think the work, again, Doug, that you're doing over there at Belmont University is just fantastic. I hope that you'll come back and update us as you continue to evolve with the program and evolve with the center. But it was a real pleasure having you on today. Thank you.
Well, thank you. Really appreciate the opportunity, and it's just been a delight speaking with you.
Outstanding. And thank you also to our listeners. If you enjoyed the conversation, please like, share, and subscribe to help us keep growing the show. And if you'd like to learn a little bit more about Taylor Healthcare and the digital healthcare experience, you can go to taylor.com/digital-healthcare. That's our show for today. And until next time, this is Chris Civitaris wishing you health and good cheer. Thank you, everyone.
To learn more about Taylor Healthcare, please visit taylor.com/digital-healthcare. This podcast is for educational purposes only and is provided with the understanding that it does not constitute medical, legal, or financial advice or services. The Digital Healthcare Experience is produced by Naomi Schwimmer. Podcast music by Nicholas Bach.